Thank you for joining us. This is KTN Mid Morning. My name is Koi. Now, within circles of friends, it's common to find yourself commenting on your friend's appearance, especially it's the first time you've seen them after a long time. Now, one of the frequent comments we make after greeting each other concerns weight. We make comments such as, "You've gained weight," or "You've lost weight." Now, such frequent comments continue to emphasize the idea that how we look and what we weigh is a significant part of who we are in society. As harmless as such comments are intended to be, there are those amongst us who take these same comments negatively and end up developing bad eating habits or avoiding to eat altogether. Today, Dr. Tanya Shaw talks to us about anorexia nervosa and bulimia nervosa, two conditions that may seem very similar but are not. That's coming up next on Mid Morning Lifestyle.
For a number of adolescents, puberty can be a very emotional, stressful, confusing, and frightening time. Some make the change from childhood into adolescence with only a few minor problems. Others, however, may have a more difficult time handling the pressures and may develop eating disorders as a way to cope. However, eating disorders are not limited to adolescents.
The kind of diagnostic criteria is, the first one for anorexia is that the person is at a weight that is less than 85% of what they should weigh for their weight and height. The next criteria is that they have a fear of being fat. They have been amenorrheic, i.e. they haven't had a menstrual period for, I think it's 3 months is the criteria. So their body weight has dropped so much so that they've stopped menstruating, and that they have they have an overvaluation of weight and shape and the importance of it, and a denial of how serious their current low body weight is. So those are your main criteria for anorexia nervosa. Bulimia nervosa is people have periods of binge eating, and we define binge eating as when somebody in a 2-hour period eats more than a normal person would eat in that period, and that while they are eating they feel out of control and unable to stop how they eat. And they then would engage in a purging behavior, so do something that they think is going to get rid of the food that they've eaten. So that can be vomiting, that can be taking diet pills, taking laxatives, over-exercising. There are a variety of different ways in which people try and overcompensate for the food that they've eaten. They also have an over-evaluation of weight and shape. And usually we're looking at those behaviors having been happening for about twice a week for about 3 months. Generally, you can understand why people are the way they are, and I find with all of my patients, you can make sense of their dilemma and how they got there, and even if their reasoning is distorted, even if their beliefs that they have to do everything perfectly in a very black and white way of looking at the world, even if they have those kind of beliefs, you can make sense of how they got there, why they are the way they are. And certainly our aim as therapists is to turn the patient into their own therapist. I need to give that teenager or that young woman, but that's who I most often see, the tools to understand how they're thinking about the world, where that thinking is disturbed, where it's adding to the behavioral problems, and how the whole problem is being maintained, so that they're more able to manage themselves. They think there is certainly a possible genetic component, and there are some interesting studies that think that it may be related to malnourishment in the womb, in utero, that there are links to later eating disorders. The trouble is, it's so difficult to distinguish what is genetic and what is environmental, because if you have a parent with an eating disorder who still has unhealthy attitudes to food and weight and body size, then you're growing up in an environment that predisposes you, as well as possibly having genetic predisposition and maybe not having enough nourishment in utero. You're anorexic, can eat very, very little. There are so many diets around now that are offering, sort of the perfect life if only you give up carbohydrates or give up fat or give up protein, all of which are incorrect, all of which cause huge problems. We need a balanced diet. But very often you will see whatever fad is around At the moment, carbohydrates are the thing that most people who want to diet think they should be leaving out of their diet. So they haven't got enough carbohydrates in their diet. I'll have people who eat a few carrots and an apple and not very much more. So people can get down to eating very little, but they still experience themselves as fat.
Although anorexia and bulimia are very similar, people with anorexia are usually very thin and underweight, but those with bulimia may be a normal weight or can be overweight.
Ideal weights are calculated in terms of what we call body mass index, which is your weight, divided by your height in meters squared. And that gives us a BMI figure. And actually it's very easy to work out your body mass index. There's lots of programs on the internet that you can just plug in those figures, your weight and your height, and it will tell you. It does vary slightly for teenagers, but as adults, we ideally want a body mass index of between 20 and 25. Under 20 is becoming too thin, and over 25, people are considered to be heavier than is healthy. So there's no gold standard, there's just what you need to be for your particular height.
Dr. Tonya Shaw emphasizes on the importance of a transdiagnostic approach. Rather than get tied up on what type of eating disorder one has, it is important to recognize that the victim has an abnormal response to food and an unhealthy eating pattern.
Well, obviously you'll have the weight loss in anorexia, which you won't see in bulimia. But with bulimia, you would be worrying about a child who was always rushing off to the bathroom after meals. But any child who's becoming socially isolated, who's maybe exercising more, who's becoming more obsessional about their food, who's counting calories, who's making comments about their body or other people's bodies, any of those kind of preoccupations with weight and shape and diet and exercise are the things that you would be flags for you to be concerned about. With anorexia, as you begin to lose weight, you've got a whole range of kind of problems that come about. There are the gastrointestinal ones. Your stomach reacts. You often feel bloated. You often feel constipated because you are constantly hungry. Because you haven't got your periods, obviously you're struggling with issues related to fertility. Your endocrine system, your hormonal system isn't working properly. So there are impacts on that. One of the big things we're worried about is osteoporosis in later life because your bone development isn't happening properly. There are cardiac problems, there are blood sugar problems. People who are very, very underweight become completely intolerant to cold because they have no body fat to keep them warm. So they're cold all the time, and they develop a thing we call laguna, which is a body hair to try and keep them warm. They often have very low pulse rate and struggle with feeling dizzy and lightheaded a lot of the time. They have, their blood pressure isn't correct either. I mean, obviously there's huge emotional problems. There's high rates of depression and anxiety, lots of social isolation, because it becomes, the thinner you get, the more focused you become about food, obviously because your body wants to eat. So the thinner and more undernourished you are, the more obsessed you are with food, the more isolated you tend to become, the more that takes over your life, thinking about food, planning about food, or not eating food, or preparing food, or it becomes a total obsession. So your concentration levels are poor, your academic work struggles, your relationships struggle, your libido goes down. So it has a very broad effect. You generally don't sleep well, got poor muscle function, lots of problems occur. Well, with bulimia, because somebody is eating large amounts of food and often throwing up, there's just the reality of vomiting regularly, which can cause, at its worst, esophageal ruptures. You can end up with sort of blood vessels in your eyes that are from the straining. There's a lot of dental problems and dental decay because of the acidity from throwing up regularly. People can end up with very unsightly marks on their hands from where they're trying to force themselves to vomit. But the regular vomiting also causes electrolyte imbalances. which can have cardiac effects. And people who are bulimic are more likely to die of a heart attack, cardiovascular problems, than say someone who is anorexic.
Treatment of anorexia is often difficult. Some individuals are notoriously difficult to help. This is because of the disorder's insidious nature, which wreaks havoc not only with the body, but just as seriously with the individual's negative self-perception.
It's difficult because the patient is resistant to the very thing that you know is going to help them, is the very thing they don't want to do. So in the beginning you are trying to help them recognize that rather than being in control, they actually feel more out of control. You're trying to break down some of their beliefs about eating and make them understand what's going on. You're giving them a lot of psychoeducation on things like that vomiting doesn't work, that you only get rid of at the most 50% of what you've actually eaten. So people think that vomiting is a weight management strategy. It's not. And of course what most people do when they're in a binge, if they say to themselves, oh well, I'm going to throw up afterwards, they eat way more than they would otherwise have eaten because they think they can get rid of the food. They only manage to throw up half of it, and therefore they've actually ended up with a calorie increase rather than the opposite. And people who think that they know that they can throw up more, they can't. It's medically proven that they can't. There's a limited amount. So a lot of it is breaking down the myths and giving people proper education about their eating and why they feel the way they do. So the beginning part is often trying to help somebody have enough understanding that they can then begin to decide to get help. And they can see that they're losing out, that their academic grades are going down, that they're not fitting in socially, that they feel depressed, more isolated. They're aware of all of those impacts. And you've got family and friends around saying, I think you're in trouble. I think there's something going wrong here.
A major advantage of an intensive outpatient program is the flexibility to design and alter individual treatment.
Ideally, we would treat people in an outpatient setting, because if we can help somebody to relearn how to eat and to manage their eating effectively while still being at home, at school, at work, in their normal life, they have learnt a skill that they can use for life. When we have to hospitalize somebody, that's a very different experience. So if somebody drops below 75% of the weight that they should be at, or if they are very suicidal or don't have a support network at home or have a history of not being able to regain weight, we would use all kinds of criteria. If their blood pressure is terribly low, or their pulse rate's very low and their blood pressure is very high, such that they're a risk to themselves, then we would be considering inpatient treatment. And those are long-term residential treatments that can be 3 to 6 months inpatient as somebody regains weight and learns how to care for themselves properly again. Hugely expensive. And the difficulty with it is it can, when control is often an issue, inpatient treatment, of course, takes away someone's control. Because if you're inpatient and refusing to eat, then you will eventually be fed by nasogastric tube, which is very difficult for somebody who doesn't want to gain weight to be basically force-fed.
The family unit is a vital aspect of the treatment process.
Well, you'd want to be very involved in their therapy and with their therapists and really trying to understand what was going on. And you'd want to have a very collaborative plan with whoever the treatment team was about what they needed to eat, what the agreements were on what they were eating, so that you could maintain that once the child was at home again. Collaboration really is the answer. And most inpatient eating disorder units will have family therapy sessions as well, so that the family are all engaged in the process and that the transition home will be as smooth as possible. What you're looking at in terms of recovery, you wouldn't be expecting someone to be totally recovered, because recovery is a process, but you would hope that their weight would be restored and they would have their periods back, that they would maybe have other things in their life that they valued rather than being thin, that they might be able to eat on a regular basis and no longer be trying to regain weight. You'd hope that they would be less depressed. Often you would be using medication. Antidepressant medication is often used in treating the eating disorders just to manage the the lowered mood as well as the impulse control elements.
Eating disorders are more than just going on a diet to lose weight or trying to exercise every day. They are extremes in eating behavior. Parents must tread carefully when they establish that their kids have developed an eating disorder.
Kids need to develop autonomy and need to have their own lives and be able to make their own decisions. So you need to approach it in a very non-blaming way and trying not to control, but just saying, I'm really concerned about this, or I've noticed that you're not eating this, or I'm worried about this. Just that lets them know that you've noticed. And certainly when we talk about, there's a very good treatment model that's come out of the Maudsley Hospital in London, and it has some lovely images of the type of parent that you need to be, and it uses the image of a very bullish parent who is the rhino, who sort of charges in and controls everything, and that doesn't help your child. Or the kangaroo who wants to put you in a pouch and protect you from everything, and that's no good. And the image that we're looking for is more of a dolphin, who's going to swim alongside your child and keep nudging them in the right direction, pointing out the pitfalls, but helping them to make good decisions in their own right. Because we can't feed our children forever. We can't control that. What we need them to do is make good decisions in their own best interests. So we really want to be finding a stance that encourages their autonomy but supports them. And kids need people to be interested in them and to value them across the board and make them feel valuable just for the human being that they are, rather than needing to achieve something or look a certain way or be a product that someone else wants them to be. So we do need a more child-centered stance that encourages children to be the people that they are and accepts them for who they are, doesn't try to mold them into something that we might want them to be when that may not be who they are, because the conflicts are within themselves and between parents and child are inevitable if they're not allowed to be who they are and encouraged in that way.
Bulimics are said to be within normal weight range, while anorexics are extremely underweight. Now, the difference between anorexic and bulimic people is that bulimics can spend all day planning their next binge, while anorexics can spend all day thinking about what they can't eat at their next meal. When recovering from eating disorders, those with anorexia work at valuing the accomplishments that they've made, while those with bulimia work at gaining control of their lives. Anorexia and bulimia are mental illnesses that can be managed and eventually cured. One approach which Dr. Tanya Shaw uses is cognitive therapy, which deals with the thoughts, beliefs, and the assumptions of individuals that affect their feelings and their behaviors. Go to our Facebook page, KTN Mid-Morning, and tell us what you think about the show, and be sure to contribute to the discussion topics. It's been a pleasure. I have been your host, Koi. Let's do this again tomorrow. Have a lovely day.